Hello, my name is Caroline, and today I'll be discussing about the abdominal focused health assessment and pain assessment. On a definition, Mr. Orr, who is 70 years old male, present to the emergency department with abdominal pain, fever, and diarrhea. He has a persistent 6 out of 10 abdominal pain, especially around his left lower quadrant, and he was extremely lethargic on assessment. Vital signs were also taken: respiratory rate 20, O2 says 95% on room air, blood pressure 100 out of 60, heart rate 88, and temperature was taken 37.3. He self-administered a gram of paracetamol for his temperature earlier, and it was 37.9. And he said that his blood pressure is lower than his normal. And he has not been tolerating oral food and fluids well due to his nausea and vomiting. And he was moderately dehydrated on assessment. He was able to pass urine without difficulties, and he had 3 loose bowel motions in the morning. Clinical and social background of the patient. Mr. O has a medical history of hypertension, depression, cold, and dyslipidemia, and also gastroenteritis. He also has a family history of hypertension and bowel cancer, and Mr. O also takes few medications as it's written, and and he's not allergic to any medications. Mr. O lives by himself, but he has very supportive 5 children, and they take turns visiting him weekly. He drinks 2 glasses of wine 2 to 3 days a week, and he quit smoking 20 years ago, and he hasn't lost any weight recently, but he said that he doesn't do exercise that much, and he doesn't have any surgical history. Let's begin with the pain assessment. Performing a comprehensive pain assessment is essential to provide appropriate pain management. Numeric pain intensity scale and PQRST pain assessment were used. The first component is P-provoke. He states that solid foods, especially oily foods, make the pain worse. Warm water and the rest make the pain settle. Quality. It's a sharp, cramp-like pain. Radiation and region. It stays around his left lower quadrant, and there are several organs written on the PowerPoint that can be found in left lower quadrant, such as sigmoid and descending colon and ovary for the female patients. And associated conditions would be diverticulitis, tubal ovarian abscess, and ruptured ovarian cyst. And the fourth component is at severity. Based on the numeric intensity scale, 0 means no pain, 10 means worst possible pain. He was having a persistent 5 to 6 out of 10 pain. And time. It is a ongoing pain. He said that paracetamol showing only temporal effects, and he has had similar pain before when he had gastroenteritis. Abdominal assessment. The first component of the abdominal assessment is an inspection, which is a visual examination of the abdominal shape, skin, abdominis, masses, and the movement of the abdominal wall with respiration. First component is abdominal contour. On assessment, it was rounded, and mild tenderness was noticed around his left lower quadrant. Secondly, it was asymmetrical, as left lower quadrant was slightly elevated on assessment. His abdominal muscle vertex was intact, and the skin was pink, warm, and there were no surgical scars observed on the assessment. And there was no evidence of respiratory restrictions, and a mass was felt in the left lower quadrant on assessment. Umbilicus was depressed, and it was underneath the abdominal surface, and there was no abdominal pulsation were observed. The second component of the abdominal assessment is auscultations, which is an examination of uttered vowel sounds, verbs, or vascular birds. His vowel sounds were absent, and it was hyperactive, which may cause inflammation and electrolyte imbalance. His vascular sounds were also absent and there were no auditable bruits. The third component of the abdominal assessment is palpitation, which is an examination for audible grating or crunching sensation of the abdominal wall, abdominal tenderness, or fat masses bruits. Light palpitation and abdominal muscarding. A mild tenderness and a pain were noticed around his left lower quadrant, and also abdominal guarding was detected, which may indicate localized or systemic infection supported in an elevation of body temperature. His rebound tenderness was also positive, which is an abdominal finding frequently associated with inflammations. Continue to palpation assessment. Lingual lymph node was also positive. Left lower quadrant tenderness to palpation with rebound tenderness, which may indicate to localized or systemic infections. Bladder assessment. It was dual to palpate, and he didn't have any urination difficulties. Liver span. Liver was not palpable. And the last component is perfusion, which is an examination a solid or fluid-filled masses, air in the stomach or bowels. On general perfusion, which is stomach perfusion, it was tympanic to perfusion. Liver was also tympanic sounds to perfusion. Spleen, tympanic on both expiration and inspiration. Kidneys, they were dual on palpation, and also he didn't have any urination difficulties. I have also assessed Mr. O's electrolyte balance as he was showing signs and symptoms of dehydration. Especially patients who have a persistent diarrhea are at risk of dehydration and electrolyte imbalance. On assessment, I've noticed decreased skin texture and also his oral mucous membranes were dry. From his urine sample, his gravity was shown 1.040. His vital signs, he was slightly hypertensive with systolic blood pressure 100, and which was lower than his normal range. Other assessments were also conducted. Stool specimen. It was type 7 based on Bristol stool chart, and the results showing positive for gram-negative E. coli. And we also performed contrast abdomen and pelvis CT, and results showing microperforation of the middle portion of the sigmoid colon. And we also performed full blood count, urea and electrolyte test, C-reactive protein test, and the results showing that hypernatremia, elevated white blood cells, and CRP. Diagnosis. Based on our assessment and data, he was diagnosed of acute colonic diverticulitis with a left lower quadrant inflammatory mass. Nursing priorities and interventions. My first nursing priority was pain management. I performed regular 4-hourly pain assessment and utilized regular and PRN analgesics, and also utilized non-pharmacological interventions, for example, warm water and a rest. And I continued on monitoring the progress of the pain management. And my second nursing priority was treating his infections. We have performed intravenous antibiotic therapy with intravenous fluids, and we have switched to oral antibiotics a few days later. And my third nursing priority was electrolyte imbalance and nutrition balance. We have encouraged oral fluids intake, and we have utilized intravenous therapy for hydration if the patient was not tolerating, and low fiber diet was also provided for his bowel rest. Management and education. It is recommended to be examined to rule out a malignancy after recovering from diverticulitis, especially for Mr. O, as he has a family history of bowel cancer. Education of pain management. encouraged to utilize non-pharmacological interventions as well as pharmacological interventions. Education of hygiene and diet and fluid intake was also encouraged, and education of healthy weight and healthy daily life are also provided. Evaluation. Pain management. His pain managed well. He was complaining of 1 to 3 out of 10 abdominal pain on numeric intensity scale. Infection status. There were no further loose bowel motion reported or observed, and he has been afebrile, and his blood results were within normal range. Hydration status. His blood pressure maintained over systolic blood pressure over 120. Good skin turgor on assessment and adequate oral intake, and therefore no longer IV fluid required. Full blood count results were within normal range. In this presentation, I have discussed about the abdominal focus health assessment, including pain assessment on the patient with diverticulitis. Nursing interventions, treatment, education, and evaluation were also provided.